Good day. It's a great pleasure to welcome you to today's ESTS webinar on the TNM 9 system and what we can expect from it in the field of lung cancer. It's a great pleasure for me to welcome Ramon Porter today. I think he's well known to every one of us. He's a thoracic surgeon working in Barcelona in Mutua Terrassa University Hospital. And he has been active forever in the ISLAC staging committee. He's been working there for more than 25 years and is the current past chairman of the International Staging Committee in lung cancer from the ISLAC. And as you know, the upcoming TNM 9 system will get into effect next year, and the respective publications are currently in preparation. And so we're very much looking forward to getting the most recent insights and up-to-date information from the person who is actually shaping the new TNM system from within. Ramon, we're very much looking forward to your presentation.
Oh, thank you very much, Clemens. It's a real honor to be a speaker in this webinar series from the ESTS. I have watched many of them, and I am very proud to be here this evening to give you a primer, actually, because nothing of this has been published except for one paper that I will mention later. So I will give you what the ISLC Staging Committee has thought to innovate in order to inform the 9th edition of the TNM classification that, as you said, will be enacted next year. I have no conflicts of interest other than my personal interest in this topic, for which I've been working for many years. So what I'm going to tell you was presented at the World Conference of Lung Cancer in September in Singapore. You can see there the speakers and the co-chairs. Dr. Asamura, who is the chair of the ISLC Staging and Prognostic Factors Committee, presented the innovations that the ISLC has proposed for lung cancer. Valerie Rush presented the innovations for mesothelioma, and Enrico Ruffini presented the innovations for thymic epithelial tumors. Paul van Schil, who is the president of the ISLC, starting from September this year, and myself co-chair that session. Please note that the 5 persons there are members of the ESTS. And I think we are proud of that, and both societies are proud of this intensive cooperation. It couldn't be otherwise. Thoracic surgeons in the era that we are living in, deal with lung cancer mainly, at least in Europe and in North America. So it is a very good interaction and association between both societies. The content of this presentation is simple. I will introduce briefly the database for the 9th edition. I will describe the innovations that we have proposed to the International Union Against Cancer and to the American Joint Committee on Cancer for the 9th edition. I will make some comments on the practical implications of these innovations. I will show you a summary slide and then the conclusions. This is the description of the database. On the left, you see this pie, and most part of it, more than 60% of the pie, comes from Asia, Australia. So we had more than 120,000 patients, most of them coming from this geographical region, but we also have about a quarter from Europe, a little bit less from North America, and a sample from South and Central America and Africa and the Middle East. In the center graph, the bars show that China is the most important contributor in the electronic data capture system, EDC. This is the registration online, and China is number 1. While on the right, you can see those countries that have contributed their own databases. They have not registered their cases online, but have sent their own databases because they contain the elements that we need for the revision of the TNM classification. And in this case, Japan is in the lead of those countries who send databases. From 120,000 plus patients, you can see there the summary of the exclusions. So finally, we have over 87,000 patients that are evaluable and good for analysis. The exclusions are reasonable, no histologic type, if there is no survival information, different tumors other than non-small cell lung cancer, no stage or diagnosed out of the study period, or no information on the T, the N, or the M descriptors, which is really important for the revision of the classification, entry errors that cannot be solved, and for most analysis, those patients receiving neoadjuvant treatment have been excluded, but these patients have been analyzed separately to understand the importance or the impact of neoadjuvant treatment on the anatomic extent of the tumor. So we are left with 73,000 patients with non-small cell lung cancer. We have a good number of neuroendocrine tumors, small cell lung cancer, large cell neuroendocrine, typical and atypical carcinoids, and 1,500 patients with lung cancers and presenting with multiple lesions, which will be useful to validate the recommendations to classify those cancers that we recommended for the 8th edition, and we have other cancers as well. This is the summary of the database. We got a similar number of patients, of evaluable patients, than we got for the 7th and the 8th edition. The most common, of course, non-small cell lung cancer, but we have a good number of small cell lung cancer, not so many as in other editions. But the innovation here is that nearly 10,000 patients have molecular data. We never registered molecular data in the previous editions. Now, once the T, the N, the M, and the stages paper are published, if budget allows, we will analyze these patients precisely. They must have full information on the TNM plus full information on molecular data. And we will try to build prognostic groups in the sense that we will have to ask how molecular data enhances the prognosis given to us by the mere TNM classification. This is one of the main objectives of this data collection of molecular data. I think that for the 9th edition, we will have to be very modest. Probably we will be able to combine stage 4 plus or minus driver mutations, but these will be 2 prognostic groups. Stage 4 adenocarcinoma with driver mutation or without driver mutations are 2 different prognostic groups. Similar anatomy, different biology, different prognosis. But what we do now will pave the way for the 10th edition. I think for the 10th edition, we will have a larger amount of molecular data, and we will be able to refine the prognostic groups combining anatomy and biology. So what are the innovations of the 9th edition? For the T component, what we did was to use the T categories of the 8th edition in the 9th edition database. And as you can see here, all categories separate very well. There is no crossing. Stage 2B and T2B and T3 are very similar in prognosis, but their differences are still significant, both at clinical and at pathologic staging. So the conclusion was that maybe it was reasonable not to change the T categories anymore, which gives us a break. We already had many changes in the 7th and in the 8th edition, so I think it was good to keep the 8th edition T categories untouched. What we did in more detail was to analyze this particular T3 descriptor, the invasion of the parietal pleura or the chest wall, because there are papers that seem to indicate that this descriptor has worse prognosis than the other T3 descriptors. And you can see it here. The blue line is chest wall or parietal pleura, aligns very well with the survival of other T3 descriptors, the red line. So they are practically the same, and they separate very well from the T4 category. So at clinical staging, T3 seems to be well aligned with other T3 descriptors. However, at pathologic staging, you can see that the blue line, chest wall parietal pleura, aligns better with the T4 descriptor than with the T3 category. So, in a sense, maybe this is something that we can expect. Pathologic staging is more precise. We have the whole specimen. The pathologist can better determine the extension and the invasion of adjacent structures. However, the tests that we have to determine parietal pleura invasion, chest wall, sometimes the mere contact does not indicate invasion. So we may fail to classify properly T3 at clinical staging. So our decision was that because there were discrepancies between clinical and pathologic T3, we decided to keep the T3 chest wall parietal pleura within the T3 category. So it still is a T3 descriptor. We have not moved this descriptor to the T4 category because of this discrepancy, clinical pathologic discrepancy. Regarding the N component, you can see here the traditional N categories, N0, N1, N2, and N3, that have been there for decades, since we have T2 since the second, N2 since the second edition. And they have been run in the database of the 9th edition, and you can see how well these 4 categories separate. N0, N1, N2, and N3, and the same at pathologic staging. And their differences are statistically significant. So this could have been enough for us, but as you probably remember, for the 7th and the 8th editions, we tried to quantify nodal disease in 2 different ways. In the 7th edition, we did it by the number of involved nodal zones. Let's remember that the nodal zone is an association of nodal stations that are anatomically proximal. So the more involved nodal zones, the worse the prognosis. And we have here in blue color a single N1 zone, in red multiple N1 zones that had the same prognosis as single N2 zone and then multiple N2 zones. So N1 multiple and N2 single had the same prognosis. And we could reproduce more or less the same in the 8th edition by counting the number of involved nodal stations. The same finding: the more nodal stations involved, the worse the prognosis. With the particular feature that here we found that N1 multiple had the same prognosis as N2 single, but without N1 disease. So the skip N2 had the same prognosis as multiple N1. Both findings from the 7th and the 8th edition derived from pathologic staging. And although we tried hard, we could not validate these findings at clinical staging. So we could not introduce this type of subclassification of nodal disease into the official TNM classification because there was no agreement between clinical and pathologic staging. However, I think that in clinical practice, this is important because for a given patient who is operated and has nodal disease, we can refine prognosis depending on the number of pathologic nodal zones or nodal stations that are involved. So it has no classification relevance up to now, but it has clinical relevance in our daily practice. However, for the 9th edition, we have found a very simple form of quantifying nodal disease that we could validate both at clinical and pathologic staging. And this is very simple. The subdivision of N2 into N2A and N2B. N2A meaning single N2 and N2B multiple N2 stations, not zones, but stations. And as you can see here, in green color, N2A, involvement of single N2 station, separates very well from N2B, multiple N2 stations involved, both at clinical and pathologic staging. You can see here N2A and N2B, and they separate very well between both of them and also among the other N categories. So the recommendation for the N component will be to separate, to subdivide N2 into N2A, single nodal, single N2 station, and N2B, involvement of multiple N2 stations. And for the M component, we have some findings that are similar to the 8th edition and others that are different. And as you can see here in the graph, the blue line, which means M1A, intrathoracic metastasis, and the red line, M1B, single extrathoracic metastasis, still have the same prognosis in the 9th edition database. So they will remain the same. You can see here, there is no significant differences between survival. In the 8th edition, the green line and the yellow line, multiple metastasis in a single organ or multiple metastasis in different organs had the same prognosis in the 8th edition. That's why we created M1C for multiple extrathoracic metastasis in one organ or in different organs. But we only had 5,000 patients for the 8th edition, and now we have nearly 15,000. So we have more power to analyze the number of extrathoracic metastases. And the finding is that when we have multiple extrathoracic metastases in one organ system, the prognosis is significantly better than when we have multiple extrathoracic metastases in multiple organ systems. And I say organ systems and not organ alone in order to avoid confusion or ambiguity. For example, if we have multiple bone metastases in the femur, in the skull, in the ribs, the skeleton is considered an organ system. So multiple bone metastases would be multiple extrathoracic metastases in a single organ system. The same would be with the extrathoracic lymph nodes. You know, the lymphatic system is an organ system. But if we have bone metastases, liver metastases, brain metastases, then these are multiple metastases in multiple organ systems. So the conclusion or our decision was to recommend the subdivision of M1C into M1C1, multiple extrathoracic metastases in a single organ system, and M1C2, multiple extrathoracic metastases in multiple organ systems. The differences are statistically significant. And this is the summary for the TNM, T no changes, and the subdivision of N2 into N2A, involvement of single N2 station, and N2B, involvement of multiple N2 stations. And M, the subdivision of M1C into M1C1, multiple extrathoracic metastases in a single organ system, and M1C2, multiple extrathoracic metastases in multiple organ systems. And these changes condition the stages, because the stages are a function of the T, the N, and the M categories. And all this is put into the computer. This slide is not to read, it's just to see the graph, the tree that is developed, analyzing all patients without metastasis. So here we just consider the N0, N1, N2, and N3, excuse me, then the T1 to the T4. And so in the end, the computer selects those tumors with different prognosis. And we have here what the statisticians call the terminal nodes, that are tumors with their own prognosis. And we have to assign a stage based on this prognosis. And the result of several discussions, several models that we discussed is this. You have here both the 8th edition TNM stages and the 9th edition stages. I put both tables together because it will be easier to see the differences in the table for the 9th edition. So the first change, the first important change is the subdivision of N2 into N2A and N2B. And the first finding was that T1 N2A had not a stage 3A prognosis. It has a stage 2B prognosis. So T1 N2A has been downstage to stage 2B. This is the first time in decades that the N2 gets outside the stage 3. So it's an important change. And we also found that T1 N1, which was stage 2B, had a better prognosis in the 9th edition database. It had a stage 2A prognosis, and therefore it has been downstage from 2B to 2A. And here, T2 N2 was stage 3A, but T2 N2A has a 3A prognosis, but T2 N2B has a stage 3B prognosis, worse prognosis. So T2 N2B has been aligned with stage 3B. Let me put this. Let's keep here. Sorry for this mistake. T3 N2 was a stage 3B in the 8th edition, but T3 N2A has better prognosis. It has a prognosis similar to stage 3A, so it has been downstaged to stage 3A, and only T3 N2B remains in stage 3B. Now, for the M1C, M1C1, and M1C2 remain in stage 4B. So there is no change. Category M1C was stage 4B in the 8th edition, and these two subcategories remain in the same stage, 4B. So no change in the M1 category. So you can see here the survival graphs of the 8th edition stages, clinical stages. The graphs, the lines separate nicely. There is no crossover. There is a degradation of survival as it is expected as tumor stage increases, and the differences in survival are significant, except for those in stage 3C and 4A. This already happened in the 8th edition, but we decided not to put together these two types of tumors because TNM is anatomy, and stage 3C and stage 4A represent different forms of tumor dissemination, of tumor extension. So despite the fact that stage 3C and 4A have the same prognosis, we keep them separate because they represent different forms of tumor invasion. And the same with pathologic stages. The survival graphs separate and they do not get together even a 10 years follow-up, and all the pairwise comparisons are statistically significant. If you compare with the 8th edition stages, they are practically the same. They look the same. And the 5-year survival estimate is also the same. We have gained a little bit in the R-square statistic. The R-square, the statisticians tell us that explain the amount of prognosis that is derived from the instrument that we are testing, in this case, the TNM classification. So we have gained a little bit, but still there is a 54% of prognosis is not explained by the TNM classification, which is normal because prognosis is multifactorial and TNM is just one tumor factor, the anatomic extent of tumor, and there are others that participate in prognosis together with patient-related factors and environmental-related factors that are not considered in the TNM classification. These findings of the 9th edition stages have been validated in different subgroups, and you have here 6 different subgroups that have shown consistent ordering of both clinical and pathologic stages. We have compared the electronic data capture system with the batch databases, squamous versus non-squamous, geographic regions, performance status, year of diagnosis, and treatment modality, surgical, non-surgical, and neoadjuvant. So I think that the conclusions that we can derive from this analysis are very solid because they can both be validated at clinic and pathologic stages and in all these subpopulations of the database. If you have seen in the previous graphs, stage 1 stage 1A is a single line, but in the 8th edition, stage 1A was subdivided into stage 1A1, A2, and A3. So we did a specific analysis of stage 1A to see if the recommendation that we forwarded in the 8th edition could be validated with the data of the 9th edition. And as you can see here, the 3 survival curves of stage 1A1, 1A2, and 1A3 separate very well. The differences are statistically significant, and most important, they separate well from stage 1B. So the recommendations that we made for the 8th edition to separate stage 1A into these 3 sub-stages has been validated and retained in the 9th edition TNM. This has also been found in pathologic stages. So what are the practical implications of these changes? First of all, I think that these innovations help us understand better the prognosis associated to the anatomic extent of cancer, of lung cancer. However, in order for these refinements to be useful, we need a precise clinical and pathologic staging. For example, we cannot classify a tumor as N2A if we perform an EBUS and we only puncture 1 or 2 lymph nodes. We have to be thorough. We have to be thorough in our clinical staging and also in our pathologic staging. If we resect lung cancer and we do not remove the number of lymph nodes that the guidelines recommend to remove for lung cancer, we will not be classifying lung cancer well according to the 9th edition, and probably it will not be useful. Another important issue to have in mind is that a mere change in the classification does not mean an automatic change in therapy. So the most drastic change that we have in the 9th edition is the downstaging of T1N2A from stage 3A to 2B. So how should we treat these tumors now? Well, we should treat them as the clinical trials for stage 3A tell us. So we don't have to treat it as stage 2B because it has been classified in this way. So taxonomy has very little to do with therapeutic recommendations that have to be derived from properly designed clinical trials. So we have to be thoughtful when we plan therapy for these tumors that have moved from one stage to another. And when there are no clinical trials recommending a certain therapy, we have to exercise our clinical judgment the best we can all together in the multidisciplinary team meeting. Regarding this important issue that a change in classification does not mean an automatic change in therapy, for the 7th edition, there are these 2 papers explaining all this. Because in the 7th edition, some tumors change from one stage to the other, and there were misunderstandings how to treat these tumors. So these 2 papers that were written for the 7th edition can be applied also to the 8th and to the 9th edition. And my recommendation is that you should read them to have a clear understanding what taxonomy is, what classification is, and what therapy is. So the summary, this is the picture, this is the slide to take a picture of. We have already seen the T, the N, and the M. In the T, no changes. The subdivision in the N, N2A and N2B, and in the M1C, M1C1, and M1C2. In the stages, T1 N2A has been moved from stage 3A to stage 2B. T1 N1 has been moved from stage 2B to stage 2A. T2 N2B has been moved from stage 3A to stage 3B. And T3 N2A has been moved from stage 3B to stage 3A. This is an important finding. Look, this is a small t, T2, with a big amount of nodal disease. So this was enough to upstage this tumor from stage 3A to stage 3B. Here we have a big T with a smaller amount of nodal disease. And this has been a finding enough to downstage this tumor from stage 3B to stage 3A. So in the absence of metastasis, nodal disease leads prognosis, as we know from other editions. So we can validate this again here in the 9th edition. Nodal disease leads prognosis in the absence of metastasis. So what can we conclude from all this? That the 9th edition of the TNM classification refines prognosis and help us to better understand the prognosis associated to the anatomic extent of tumor. But in order to refine prognosis, we need a detailed clinical and pathologic staging. If we don't stage clinically and pathologically well, we cannot classify well in the 9th edition. For the 9th edition to be useful in clinical practice and research, we need to emphasize the importance of a detailed clinical and pathologic staging. Well, the TNM classification has been active since almost 6 decades. Pierre Denoy, a surgical oncologist from France, worked for a decade investigating the anatomic extent of tumors. The classification that he organized to classify tumors was very different from the TNM that we have today. Probably he would not recognize his own classification in view of what the TNM is today, but he put the basis to classify tumors based on the anatomic extent of tumor in 3 different components: the primary tumor, the nodal involvement, and the metastatic involvement. Clifton Mountain developed the lung cancer TNM. All the descriptors that we use today were already in the 2nd edition of the TNM classification that was based in the database that he collected and managed, a database from the North America. Peter Goldstrow gave an international character to the classification. He had the idea to collect an international database, not only surgical cases, but also of all types of therapies. And thanks to this initiative, we had the International Association for the Study of Lung Cancer staging project that has been running for more than half of the history of the ISLC. So he himself chaired and completed the first phase of the staging project, producing the 7th edition. The second phase was concluded successfully with the 8th edition, and now we are about to complete the 3rd phase of the staging project led by Dr. Asamura, and all the TNM papers will be hopefully accepted and published at least online before the end of the year. The 2 papers that are already published regarding the 9th edition is the one describing the database and the N paper. The N paper is already online. The T and the M papers are submitted, and we are waiting for the comments of the peer reviewers. The 3rd phase is already starting to be organized. Valerie Rush, who has been chair-elect, will become chair during the next World Conference of Lung Cancer in San Francisco in September next year. And we also have, and she will lead the project to the 10th edition. And we have already elected Raymond Osaro-Jagbon, who is a medical oncologist from the USA, who has a very surgical mind. He has done an enormous work trying to improve staging in the area of his influence in the Tennessee and in the southern states. And he will be the only medical oncologist who has been chairing a project, and I'm pretty sure that he will do a great job, because all the papers that he has published based on the project that he's done in his area are very substantial. He's very active and very reliable person. So I think that the ISLC staging project still has a long history to go for the benefit, for the refinement of the TNM and for the benefit of our patients. So this is all from me. I will take questions delightfully, and I thank you for having me with you. Thank you very much.
Yeah, thank you very much, Ramon, for this excellent presentation and overview, and also for clearly highlighting that change in the staging now does not necessarily or does not directly implicate a change in therapeutic strategies. There are several questions actually related to this topic. So maybe can you highlight a little bit? Of course, the change in the prognosis is also a change in therapeutic strategies for certain situations, which lead to the results we see here. What practical implications would you see as meaningful based on the new TNM classification? Do we need a more thorough staging? Do we need a more thorough lymphadenectomy? Do you think that a change in these recommendations could be warranted?
Yes, I think that the fact that we could validate at clinical staging the subdivision of N2 into N2A and N2B is extraordinary. We couldn't do that in the 7th and the 8th edition. And I think that this reflects the fact that we are better at clinical staging. We use more PET-CT, we use more EBUS, maybe some use more mediastinoscopy, I don't know, but in fact, the finding that N2A and N2B have been validated at clinical staging is a real novelty in these 3 editions. So it means that the clinical staging is closely resembling pathologic staging, which is the more real, right? If we do it properly, pathologic staging reflects more clearly what the reality of the tumor is. So if this is so, I think it pays off to invest time and efforts in clinical staging. If we want to classify a tumor as T1N2A with certainty, we have to invest time in examining the mediastinum. So as I said before, now in most institutions, PET-CT is available. In most institutions, or every day, it's more frequent to have EBUS, but EBUS must be thorough. If you review the published reports, the average number of lymph nodes puncture is 1.2, 1.5. So most endoscopies puncture the hot node, the one that is evident on PET-CT, and they don't puncture the others. We cannot classify a tumor as having a single N2 station by only doing that. My recommendation, and I think that the recommendation that is derived from this division of N2 into A and B, is that clinical staging has to be more precise. And I think that we have gained in this year since the 8th edition, but we have to insist. If we do mediastinoscopy, we have to do something else than just scope the mediastinum, right? Some people say, well, mediastinoscopy is to scope the mediastinum. You don't really need to take biopsies. Well, no. The definition by Carlens was that mediastinoscopy was a method of inspection and taking biopsies of the mediastinum, not just inspection. So if we put the instrument in, we have to take advantage. We're already there, so we have to be thorough. We have to biopsy or remove the lymph nodes that are available, that are reachable in our exploration. The same at resection. By VATS or by thoracotomy, we have to open the mediastinum and remove the lymph nodes that we see, that they are there. So it's the only way to properly classify N2A and N2B. Otherwise, then survival or prognosis will disagree with the graphs that I have just shown you. You know, you will say, well, our patients go worse or go better, but if there is a disagreement, it's because the staging has been not so thorough as it has been in the institutions that have registered cases for the 9th edition database. And as I said before, if we don't have clinical trials, we have to exercise our clinical judgment. So should we operate T1 and N2A upfront? Well, it depends on the decision of the MDT. We don't have trials for that. We know that if we operate them, we have better prognosis than stage 3A, their old stage. But why to operate upfront? There is no trial indicating that we should do that. But of course, if that's the decision of the MDT, it's reasonable. And then give adjuvant therapy, depending on the molecular markers that the tumor has. If there are no markers, where the classic chemotherapy. If there are markers, where we can give target therapies or immunotherapy according to the new trials. But we have to do that thoughtfully. We have to think about it. We have to think what we are doing, not just like a reflex. So we have downstage that tumor, so let's go and operate. Now, I think we have to think properly with our colleagues in our multidisciplinary team.
There was a question addressing sort of the fear that the different TNM systems and used in different studies might cause confusion. This was already the case with stage 1B versus stage 2 at the migration from TNM 7 to TNM 8, and had to be carefully addressed. And now again, we have a situation where the system is updated, and of course it leads to a refinement in the prognostic classification of the patient, but it might lead to some confusion, particularly when the first studies are coming out that are using the TNM 9 system versus the TNM 8 system. So what would you recommend, or what are the details you would look at, or which recommendations would you give to people who are in fear of that mix-up?
Yes, I think that for new studies, we should use the latest edition of the TNM classification. I think that most changes are compatible retrospectively. So N2A will only be N2. So the only thing is that if we don't have the number of involved nodal stations that we had in our old series, we cannot reclassify those tumors from N2 to N2A, right? Or N2B if there are multiple. But this will be a problem. This has been a problem in every edition. Not all changes are compatible retrospectively. But if we don't change, we don't make any progress. So I think that we have to assume that some tumors will not be able to be reclassified. Only those databases that have the number of stations involved will be able to reclassify their tumors from the 8th to the 9th edition, for example. If you don't keep the data, you cannot reclassify. But again, maybe this is not so important. I mean, we have to look forward and to start new trials and new registration of cases into new databases based on the new edition. All that said, I would add that it is not an obligation to use a certain edition of the TNM. We are very rich in TNMs. We have 8th editions now, and we have 9. We will have 9 in a matter of months. So you can use whatever you want, but you have to mention it. If you are writing a paper and you want to use the third edition, go ahead, but mention the third edition, right? Because a TNM is an international language, and we have to know what language and what variety of the language we are using. And the language has been changing slightly from edition to edition, and we have to apply the right language to the right situation. So, you know, for the 8th edition esophageal cancer, many people did not like the 8th edition, and they kept using the 7th edition, which is very reasonable. So as long as you mention that you're using the 7th edition to avoid confusion and ambiguity in the results that you are publishing. So in essence, yes, there will be problems. Not all changes are compatible retrospectively, but these changes are made in order to push the classification forward and to better understand the prognostic impact of the anatomic extent of the cancer.
The number of positive lymph nodes, or the ratio of positive lymph nodes, is something that is not taken into account now for the TNM9. Do you think this is still a worthwhile factor taken into account for future analysis?
Yes. All quantifications that have been tested at pathologic staging, so that means deriving from the lymph nodes removed, work very well. The number of lymph nodes removed, the ratio of the number of positive nodes to the number of nodes removed, the number of lymph node stations, the number of lymph node zones, all of them are prognostic at pathologic staging. But when you want to validate that at clinical staging, it doesn't work. They don't work, all these types of quantification. So that we were very happy to see that this simple quantification of nodal disease could be validated at clinical staging. And we chose this because it was the simplest. The quantification of N1 also works, but it is more difficult to quantify N1 disease. You can reach certain N1s, but not all of them. You can reach the hilar ones and maybe the interbronchial ones, but not the segmental ones. So I think that this sort of quantification may facilitate more complex quantification of nodal disease in future editions, again, if clinical and pathologic staging is thorough enough to account for the number of involved lymph nodes, both at clinical and pathologic staging. I think that nowadays, by using the procedures that we have, PET-CT, mediastinoscopy, or transcervical lymphadenectomies, PET-CT is not enough to quantify nodal disease by the number of lymph nodes. The stain, the uptake that we see, maybe one lymph node, maybe two, maybe three. It depends on the projection that you see the image. So I don't think it is accurate enough to be able to count the number of positive lymph nodes. And also we have to consider that there are positive lymph nodes that are normal in size and that do not get any uptake. You can only quantify, probably with the highest certainty, if you do a very thorough mediastinoscopy or a lymphadenectomy. By doing that, I think that the clinical N will be very similar to the pathologic N. And then the quantification that you want to use, either the number of involved lymph nodes or the number of removed lymph nodes or nodal stations, will be more accurate. But I don't think that we are there yet. So let's start with this simple quantification by subdividing N2, which is a very drastic change, by the way. But I think it was important because there is also a general feeling, and there are many papers indicating that the amount of nodal disease is prognostic, and that it is not the same to have only one nodal station involved or several, or only one lymph node or several. So I think that this change is feasible to do at clinical and pathologic staging if we are thorough with the means that we have today, and to apply them properly and to the maximum advantage of the test that we are using. If we are using EBUS, so let's do it in the more thorough way. If we are doing mediastinoscopy, let's explore all the stations that we can reach. If we do VAMLA, let's remove all the fatty tissue and all the lymph nodes that we can remove in the nodal stations that are reachable by VAMLA. If we do a thoracoscopy, the same. Let's be thorough. Let's not leave nodes behind, because if we leave nodes behind and the pathologists don't have them under the microscope, we will never know the status of those lymph nodes that we leave behind.
There's been updates on the M&M descriptor, but not on the T descriptor this time. Do you think we have all the information for T description, or there's anything in particular worthwhile collecting for future refinements?
I think that for the T3 and the T4 categories, if we had enough patients without anything else, I mean, without metastasis, without nodal involvement, fewer T4, if we had more than we have now, maybe we could separate some good T4s from the bad T4s, because there are some data indicating that not all T4s are the same, and on the condition that they are N0, right? But we have several thousand T4s. But when you break down the numbers and then you separate, okay, superior vena cava, carina, aorta, recurrent nerve, esophagus, you are left with very few numbers and the results are meaningless. So I think that if we had more cases, pure T4, N0, M0, we could probably refine this category, maybe T4A, T4B, something like that. The same with certain T3. You see the discrepancy between T3 clinical and pathologic in the chest wall and parietal pleura is intriguing. I think that what reflects reality is a pathologic T3. I think I believe, I'm sure that probably T3 parietal pleura and chest wall is closer to T4 than the T3 category indicates. But again, we should prove that also at clinical staging, and we don't have that. We don't have that proof. And we need more data and maybe better clinical staging to ascertain whether the parietal pleura is involved or the thickness of the chest wall, and we don't have that. At least we don't have it in the 8th edition.
Okay, thanks very much. So we're exactly on time now at the end of the webinar. Thanks again, Ramon, for this excellent presentation and discussion. Also, thank you for all the participants for joining us in this webinar. And before we end, I would like to draw your attention to 2 upcoming webinars. The next one will be on November 29th, an AstraZeneca-sponsored webinar on the very current topic of which type of resection we should use for sublobar resection, wedge versus anatomical segmentectomy. And the next ESTS webinar will take place on December 11th, and Olaf Mercier from Paris will talk about ECMO in thoracic surgery. So once again, thanks for joining us today, and looking forward to see you soon again.
Thank you. Bye-bye.
Bye-bye.